Hi all, I'm Malavika, and in this video I'll be explaining about calcium channel blockers. Coming to the classification, calcium channel blockers can be broadly classified into two categories: dihydropyridines or DHPs and non-dihydropyridines. Dihydropyridines include drugs like nifedipine, amlodipine and cilnidipine, and non-DHPs can be further classified into two types: phenylalkylamines and benzothiazepines. An example of phenylalkylamine is verapamil, and an example of benzothiazepine is diltiazem. Coming to the mechanism of action of calcium channel blockers, calcium channels are of 5 types: L, N, T, P and R. L-type channels are mainly blocked by calcium channel blockers. L-type voltage-gated calcium channels are mainly found in the cardiac and smooth muscle cells. An L-type voltage-gated calcium channel consists of mainly 4 subunits: alpha 1, alpha 2 delta, beta and gamma. Calcium channel blocker will bind to the alpha 1 subunit of the channel, thereby preventing calcium influx into the cell. Therefore, there will be no excitation-contraction coupling, and this will lead to cardiac depression and vasodilation. Coming to the pharmacological effects of calcium channel blockers, they cause vasodilation. Arteriolar vasodilation will decrease the peripheral vascular resistance, so the blood pressure will fall. They also cause coronary vasodilation. On the heart, they have negative chronotropic effect, that is, they decrease the heart rate; negative dromotropic effect, that is, they decrease the AV conduction; and negative inotropic effect, that is, they decrease myocardial contractility. Calcium channel blockers have no significant effect on veins, so there is not much effect on the venous return. Preload depends on venous return, so there will be no effect on preload. It is only the afterload that is decreased due to decrease in peripheral vascular resistance. Dihydropyridines mainly act on the vascular smooth muscles, so they cause coronary as well as arteriolar vasodilation. As a result of arteriolar vasodilation, the peripheral vascular resistance will fall, so there will be a decrease in the afterload against which the heart has to pump blood, and this will also decrease the oxygen consumption of the myocardium. Both verapamil and diltiazem cause cardiac depression. Verapamil has got maximum depressive effect on the myocardium, followed by diltiazem. Although dihydropyridines have least cardiac depressive effect, they are the most potent vasodilators among the three. Nifedipine is the prototype dihydropyridine. It rapidly attains peak levels in blood and causes rapid vasodilation and fall in BP. This will lead to reflex tachycardia. Amlodipine is the preferred dihydropyridine as it is more potent compared to nifedipine. It has a longer duration of action, less extensive first-pass metabolism, high oral bioavailability, and less side effects compared to nifedipine. Felodipine has got greater vasoselectivity compared to nifedipine and amlodipine, and nimodipine has high lipid solubility, so it can easily cross the blood-brain barrier. Coming to the pharmacokinetics, calcium channel blockers are well absorbed through GIT. They are highly bound to plasma proteins, and metabolism is mainly hepatic. They are excreted in urine. Adverse effects of calcium channel blockers: verapamil causes constipation, nausea, bradycardia and edema. Diltiazem causes headache, bradycardia and edema. Nifedipine causes palpitation, flushing, reflex tachycardia and edema. Uses of calcium channel blockers can be classified into two categories: cardiac and non-cardiac. Cardiac uses include angina, hypertension, supraventricular arrhythmia, and hypertrophic cardiomyopathy. Non-cardiac uses: nifedipine, amlodipine, felodipine, and diltiazem are used to treat Raynaud's phenomenon. Raynaud's phenomenon is a condition which occurs in response to extreme cold or stress. There will be discoloration in the extremities, such as fingers and toes, due to decreased blood flow. Verapamil is useful for prophylaxis of migraine. Nifedipine has uterine relaxant action, so it can be used in case of premature labor. Nimodipine decreases cerebral vasospasm, so it can be given to patients with subarachnoid hemorrhage. Finally, we have the drug interactions. Verapamil and diltiazem cannot be given with beta blockers as this can lead to severe bradycardia. They also increase plasma digoxin levels by decreasing digoxin excretion. So that's all about calcium channel blockers. Thank you for watching.